Hello, everyone, and welcome to the International Orthopedic Diversity Alliance Journal Club, paired with the JBJS, as well as co-sponsored with the American Association of Hip and Knee Surgeons. Also hosted with the University of California, Davis Medical Center and the University of Minnesota Orthopedic Department as well. I wanted to thank everyone for taking the time out of their busy schedule to come and learn about the science of diversity in orthopedic surgery. My name is Zach Lum. I am a practicing hip and knee surgeon at the University of California, Davis. I also serve on the AUKUS Diversity Advisory Board as chair, and I'm delighted to have our esteemed guests and wonderful residents present these fantastic journals about a topic that is very important to all of us. So with that, allow me to please introduce our esteemed guests and residents. First, Dr. Antonia Chen. Dr. Chen hails from University of Texas Southwestern in Dallas, and she is the chair there with her fantastic orthopedic surgery department. We also have residents, Dr. Anthony Bitar from University of Minnesota. He is in his chief year. We also have Dr. Hannah Day, who is a orthopedic resident at UC Davis in her third year of residency training, and also Dr. Shannon T., who is in her first year of orthopedic residency at University of California, Davis. Welcome, everyone. With that, I would like to start. We have a nice 3 articles to discuss regarding the science of diversity. And we would like to first start with the article from the Journal of Bone and Joint Surgery, published in 2024, titled Education, Language, and Cultural Concordance Influences Patient-Physician Communication in Orthopedics.
All right. Can everyone see my screen? All right.
It's in presenter mode.
Oh. Second. Just share the other screen. Are you able to see the actual presentation now?
Yeah.
All right, awesome. Well, my name is Anthony again. I'm from University of Minnesota. I'm one of the 5th-year residents going to Arthroplasty, the best subspecialty. So I'll be presenting the first article titled Education, Language, and Cultural Concordance Influence Patient-Physician Communication Orthopedics. These are the authors, and it's from University of Illinois in Chicago. So introduction, the question that the study kind of aims to answer is, does education, language, and culture concordance influence communication in orthopedic care? This examines the relationship between the patients and the orthopedic surgeons and the influence of communication quality on their satisfaction and their perceived understanding of their care. And this is in an urban orthopedic practice. While disparities in orthopedic outcomes by race and ethnicity are well established, there hasn't been much studies exploring how educational attainment and patient-physician language and culture concordance examine the relationship and communication between the orthopedic surgeon and their patients. So prior research exists in this, however, it's mainly in primary care and other specialties. So orthopedic surgery lacks this data in our field. So this study kind of aimed to fill the gap on the impact of patient education level on communication, the effect of language concordance in musculoskeletal care, and cultural concordance in patient satisfaction as well. In terms of the methods, this is a cross-sectional survey study. It's done in a single urban tertiary academic center from 2021 to 23. They included 394 patients, and these patients were returning patients. They excluded any new patients, and they were being evaluated for elective surgery. They also had 8 blinded surgeons involved in the study. Those surgeons were from varying culture background and language proficiency. They had some surgeons that were proficient in speaking Spanish, and some were Hispanic and Spanish speaking. So both culture and language concordance with patients as well. And some were neither. They administered a survey that was a Likert type survey based on patient satisfaction questionnaire, and it was modified for culture and language assessment. They assessed race, ethnicity, education, language proficiency, culture importance, and communication quality and satisfaction of the patients. They defined Hispanic culture language, Hispanic culture and language concordance as a Hispanic patient treated by Hispanic surgeon. The administrators were bilingual as well. They had appropriate statistical methods for a cross-sectional study. In terms of the results, they demonstrated that educational attainment strongly predicted communication ability. So patients with at least a high school diploma communicated significantly better with their orthopedic surgeon compared to patients with a middle or elementary school education level. Hispanic patients reported lower English proficiency and worse communication with surgeons compared with white and African-American patients. And Hispanic and African-American patients place greater importance on cultural understanding from their orthopedic surgeon compared to white patients. And among the Hispanic patients, language and culture concordant surgeons increased patient evaluation of Spanish-speaking ability. And finally, just highlighting some of the important results as well in their subgroup analysis of Hispanic patients. They found that Hispanic patients understood surgeons better in Spanish, 75% of the time, than in English, 51%, and expressed concerns better in Spanish as well compared to English, 70 versus 48%. In terms of looking at and evaluating this article critically, the study question was clear, and it was clinically important. It is a cross-sectional observational study, so it's a level 3 evidence. They had appropriate methodology and design. They did have robust internal consistency with clear differences by education and ethnicity. There might be some selection bias considering that they had kind of convenience sampling of patients that were returning to clinic. And there might be some courtesy bias, patients being surveyed in clinic during their clinic visits. So it's something to keep in mind, but it's just some of the nature of a cross-sectional study. It is highly clinically relevant and kind of highlights the systemic need for diversity in recruitment and training in cultural humility. In conclusion, the education level seemed to be a major driver of patient-physician communication among all patients, with high school education serving as a critical threshold for comprehension. Hispanic patients face the greatest communication challenges, largely due to English proficiency gaps, and benefits substantially from Spanish-speaking, culturally concordant surgeons. Cultural understanding is highly valued by African American and Hispanic patients and is associated with better perceived care. And they also highlighted improving communication requires both language concordant providers and culturally humble clinical interactions. So orthopedics as a specialty, we must work to recruit a more diverse, multilingual workforce and improve health literacy interventions. Some of the discussion points, like I mentioned, this is a cross-sectional study, so it has its own limitations. However, it does highlight the importance of culture, humility, and diversity. And I guess the question to kind of present to the panel is what interventions would you take in your clinic space to help address the educational and cultural disparities in orthopedic surgery without limiting access to care? Because I think that is something that is important when trying to address these limitations is also not having limitation in terms of access to care. Some of the things that I thought about, for example, having Hispanic, Spanish-speaking surgeons, for example, to address the results that they had in the study is instead of having those surgeons, for example, in the same clinic day on the same day, having them kind of mixed with patients that have different backgrounds. That way, to allow different, more broad access to care for those patients. Just something to think about.
I appreciate your presentation there, Anthony. So how many Hispanic or Spanish speaking surgeons do you think that are there out there?
Not many. I think the study said that underrepresented the minority in orthopedics is less than 5% of orthopedic surgeons. I think I'm not sure how much of those are even Spanish speaking. So overall, not many, I would assume.
Really not many, right? And the good news is you don't have to be Hispanic in nature to understand Spanish per se. But this talks to a cultural perspective. So is language enough, or do you really want to understand someone's culture? And which one do you think matters more to a patient?
I mean, I think it's both. It's probably a combination of both culture and language, and that's kind of what the study highlighted as well. Is obviously being able to communicate in a language similar to the patients is helpful, but it seems like Hispanic population, African American patients both valued the surgeons understanding their culture as well. So I think it comes from both directions. And
Perfect.
that's kind of the question is like how to achieve that because it's going to be a long-term goal to be able to recruit a diverse group in orthopedics. And it seems like the article was highlighting that right now for the current cohort of orthopedic surgeons, it's important to also train in culture humility. So I think it's a combination of both culture and language, and also patients having knowledge and training and humility as well.
We'll agree on all those counts. And from a culture perspective, I can talk to you about my culture, but do people from different cultures typically want surgery or don't want surgery?
So I'm originally from Syria, so I know in my culture at least, and most cultures that I've interacted with, they try to avoid surgery, and
Always.
most patients don't want to have surgery. So um,
That's just like my mother. I
yeah,
know
I
that
was
she
gonna
would
say,
benefit from it, but she just does not want it, you know. I
my
do
mom needs
agree. I
surgery so
mean,
badly.
I know
Same thing.
I do agree that the population for the Latino surgeons is very low. I think based on our last census poll, it was somewhere in the teens, or actually even less than that. I think it was in this bridging on the single digits, but we know that the Hispanic population is ever growing. And so we do definitely have organizations that help mentor um, people of Latino and Hispanic background to learn what it's like to be in orthopedic surgery and help get them into
You froze up for me. Did he freeze up for you guys too?
yeah.
there was some
Unfortunate.
discussion
Okay.
about doing, Spanish clinics. You just have to be a little careful that you don't want to segregate these clinics. You want to make sure that, you're providing care. It's the same level of care, same equitable amount. So that was the only thing that I just wanted to add in. Um, I'm curious, Dr. Chen, for you, um, what do you think is, sometimes, we have to, how healthcare is now, we have to quickly move through clinic, see more patients, have less time. What are your kind of steps for patients that maybe need some additional help, may need an interpreter, may need some language assistance, or educational um, uh, tools? What do you guys do at UT Southwestern?
So two things. One, I really like what Professor Eastwood said in the question and answer session there, where she said at least open up with some welcoming words. And I don't speak Spanish well, unfortunately, but I'll say, "Hola, ¿cómo está usted?" I say, "Donde duele?" How long have you hurt for? "Donde duele?" And then just say some words in Spanish to kind of just open up the conversation, and that helps patients feel a little bit more comfortable. We do use interpreters. We have in-person and the camera interpreters, which are actually pretty excellent. Sometimes even with patients with family members who are willing to interpret, they'd rather have an interpreter there because they don't want to mess something up. So it takes a little bit more time, but I think it shows that you're willing to meet them where they are at in their conversation, and they're way more comfortable conversing in their own language than in English or any other language. So we take the time to do so. I just recognize it's going to take more time, and that's okay. I do like the idea. We don't have not all of our attendings speak Spanish or other languages that come in. I will say that the concordance, I can speak some Chinese, Mandarin Chinese. And when I was in Boston, I was able to speak Mandarin Chinese to a bunch of my patients, and that was really helpful for understanding concordance. And people with the fear of surgery is real. And there's lots of studies that show that people of different ethnic backgrounds are less likely to get surgery for the same level of arthritis, for example, for a hip or knee replacement. And so being able to talk to them and recognize their fears and allay their fears as opposed to saying, you just need surgery and you walk out. I think spending time with them means a lot to them as well, too.
Absolutely. And one thing that I try to do even when I'm using the Spanish video interpreter is I will just ask the patient, not only do you understand what I said, tell me exactly what we talked about, so that that old teach back method, it does take time, but I think it's sometimes can be worth in the end.
Totally agree. Do you guys do anything differently?
We do have we do have different language packets. Um, just pretty much Spanish. But and we have obviously the video interpreters. We used to have in-person interpreters, but I think metrics have changed a little bit. One thing that is kind of cool that we have in person is ASL. And so we have people that come in the clinic and personally, I think in person has that deeper human touch that people enjoy, but we work with whatever confines that we have as well. So I definitely think that having that aspect of it can really, um, help uh, make the patient feel much more comfortable, and that really kind of gives them a culture that we really truly care about them and are invested in their own health.
Yeah, I appreciate the fact they had clear masks during the pandemic, and if they had ASL, they'd actually had those so they could read their lips while doing sign language. It was really cool.
That's awesome. Okay, I think we can move on to our next topic. It's the core article. How long will it take to reach gender parity in orthopedic surgery in the United States? Dr.
Me
T.
share my screen. All right, can we see the full screen there? Okay. So it's not loading. There we go. So the title of this article is How Long Will It Take to Reach Gender Parity in Orthopedic Surgery in the United States? An analysis of the National Provider Identifier Registry. Here are the authors and their affiliations. Of note, Dr. Chen was also an author on this paper. It was published in Core. Um, So brief summary about the paper first. So as we all know, orthopedic surgery has the lowest proportion of women among all the surgical subspecialties, and gender disparities unfortunately do exist in our orthopedic world in terms of salary, leadership, authorship, in terms of research, publications, as well as industry payments. So this study states that prior literature examined trainees only, and there were no comprehensive national analysis across regions, specialties, and prior literature had relatively smaller samples. So the aim of the study was to evaluate how have the overall regional and subspecialty percentages of women among all currently practicing orthopedic providers changed over time in the US. In terms of the methodology, this was a retrospective cross-sectional study using the NPI registry, which was a national database of all registered providers during the years 2010 to 2019. They included surgeons with relevant orthopedic or subspecialty taxonomy codes, and gender was self-reported through the NPI registry. They excluded trainees, non-physicians, and providers who did not associate orthopedic specialty to their code. And they used cross-sectional annual proportions for each year at the end of each year. They used linear regression to calculate temporal trends and compound annual growth rates for the national, regional, and subspecialty growth, and used Holt-Winters forecasting to forecast time to gender parity. In terms of their key results, they found that women increased from 6 to 8% within those 9 years, meaning a 2% compound annual growth rate. They projected gender parity in orthopedic surgery to be achieved in 217 years. That's by year 2236. There was growth everywhere, highest in the Midwest at 27% and lowest in the West at 17%. Pediatrics and foot and ankle had the highest growth within those 9 years. Adult reconstruction and spine had the lowest. In the year 2019, as of end of that year, pediatrics had the highest female representation at 26, adult reconstruction and spine at the lowest at 3%. What the authors concluded was that at the current rate, gender parity would take more than 200 years to achieve in orthopedic surgery. The growth was slow across all regions and subspecialties, and they recommend that changes are needed at every level, including at medical school, residency, and leadership within professional societies. One of their suggestions was to require dedicated exposure to orthopedic surgery in medical school to increase interest earlier in training, and to set benchmarks among all levels, including trainees, faculty, program directors, and leadership roles in order to invest in the academic and professional development of women surgeons. Just a little bit about the paper's strengths and weaknesses. So this uses a large national database, providing pretty large sample size and broad workforce coverage. Their methodology was pretty clear and helped answer the aim of the study directly. And their methods allowed long-term projection for gender parity. Some limitations, again, self-reported taxonomy codes might not be entirely accurate. And for example, there was no option to report shoulder and elbow as a specialty, only sports medicine. And they only included male and female gender, so some non-binary providers may be excluded. With the univariate models, they might not have accounted for any confounders, and the subspecialty forecast assumes constant future growth. It might not be at the same rate over the future as well. Clinical implications, again, as I mentioned before, they highlighted the earlier need for exposure to orthopedics for women in medical school. As we all know, a lot of medical schools don't have orthopedics as like a required specialty. And they've also suggested to support targeted recruitment efforts in regions and subspecialties with minimal growth, as we all are aware. For example, at UC Davis, we have the Parity Initiative and Nth Dimensions as well, to help with that. And again, reinforcing the importance of faculty diversity, mentorship, and role models to help in faculty. So start with a discussion point, as Dr. Lum and Dr. Chen are both arthroplasty surgeons. Why do you think, what factors might explain why your specialty might have the slowest growth among women surgeons?
Well, thank you for presenting that, Shannon. That was excellent. Very sobering article in some ways, and there's a really good point in the chat that I'm just going to bring up. But to answer your question directly, I see it as an opportunity for growth, if anything, as opposed to it does seem very negative. It's interesting because as a whole, the percentage of women in spine is less than the women in arthroplasty in the orthopedic space, not including the neurosurgery space. Interestingly enough, orthopedics has a lower percentage of women than neurosurgery does by percentage, not by number. But it is going to hopefully get better with time. And I think really what it is perception. And I think as we have more and more people who go into the field, it's going to hopefully change that perception. So perception arthroplasty is you need to be strong. You have to lift big legs and knees. And it's true. There are big legs, there are big hips. But I always say use help. You have people in a whole entire operating room who can use your help. And it's not about working harder, it's working smarter. So we jump on the bed and do a hip dislocation. Is that the best way to do it? Not necessarily, right? So I think what happens is there's still a perception for arthroplasty and spine, maybe have not as good hours and that sort of stuff like that. And I think one of the biggest things that was a draw for women who are in my group, we're seeing people who were mentors who were women, and then they wanted to go join that field. So as we have more and more women joining the fields of arthroplasty and spine, more and more people will be like, oh, you look like me and you do arthroplasty, you do spine, and I think you do a good job. So in that case, I think it's a good thing and a good win overall for all that.
Absolutely, totally agree. Couldn't agree more with that. I'd say, and I was fortunate enough to be at the AOS Educators course this last week, and it's we were talking exactly about individuals and recruiting people that look like you, because they have the same shared experience and just being able to communicate more, not only to their peers but the patients and what have you, which we just kind of talked about in the prior article. And there's this, I guess this, it was, I didn't know about this less than a week ago, but apparently there's this culture, and it's been populated in like board finance and Fortune 500 companies, that once you reach a critical threshold, that's when behavior changes, that's when biases change, et cetera. And so I think it's important to be able to increase those numbers so that you reach or go towards parity, so that you can improve the overall culture of the department, or the C-suite essentially. But it was very fascinating. The research has been around for like maybe 20 years or so, looking at that specifically regarding board of director companies in Fortune 500 companies. And so and it makes sense. Here we're very fortunate at UC Davis that our chair is an ally and is very just pro-diversity. And we have the highest female faculty to resident ratio. And I think that the department is amazing and awesome. And I just want to put a plug out there. I didn't recruit our two female residents to come to this journal club. So we have more as well. But these were our two of our main stars. So we're happy to have them.
So I know I want to bring up something here with our two female residents on the call. Anthony, you're also awesome too, I promise. But having the two females on this call highlights something that Dr. Weber brought up in the chat, which is really, really good point. She's highlighting a 2024 article by Buckley et al. And it shows the effect of sustained outreach to improve gender parity in orthopedic surgery. So this data had used AMC, it used, the national registry about people who did Medicare cases. This other study, the Buckley one, was an AAMC data on PGY1 women ortho residents over time. And it showed that the increase in women in the PGY population went from almost 15% to now 21% from 2008 to 2022. And there's really a lot that happens with regards to mentoring. Who here participated in a Perry initiative before? I don't know if you guys ever participated in those, but at least know about them. And I know it's really impacted engineering students, medical students, et cetera, to know what it's like to have a power drill or to put a nail in and things like that. So they're assuming that if we continue the intervention at the present levels, for the PGY class to reach peak diversity of 28%, it would be 2028. So that's not that far away if you kind of think about it, right? And a steady state of approximately 25% practicing female orthopedic surgeons by 2055. So, we're making assumptions here. We're assuming that everyone who does residency continues in the workforce as attendings, and we know that's not always the case for men and women for whatever reason. But it just shows that there might be actually a better horizon as opposed to the 327 years we have to wait for US parity versus medical student parity. But there is some hope in the horizon. Professor Eastwood has made that there's, and I don't think she's naive about this at all. I think she's optimistic that there's a tipping point sooner rather than later. And in the UK, the non-orthopedic colleagues are dismissive of orthopedics when they talk to students, saying they should be anything but a surgeon. And I think seeing more and more mentors on the stage, seeing more and more people out there, you residents are so instrumental in talking to our next generation. Men supporting women, people supporting underrepresented minorities. I'll say my mentors were a mix of men and women. And my first mentors were men, and they supported me all the way here now. So, I think there's a lot to say about orthopedics about just supporting people into the field. And I think we actually will look back at this paper, hopefully, and said, oops, they were wrong. We hit parity a lot sooner. So that's how I hope. I'm hoping my paper was wrong.
Awesome. Yes, great commentary. Thank you so much for that. It's nice to have secret insight from the own author. So, we talk a lot about things that we can do to kind of improve that, to accelerate that, the role of reaching parity. They talk about maybe even implementing some benchmarks we do for women trainee, but also faculty or program directors or even society leadership. Is there one metric that you think, if you could pick one focus point, Dr. Chen, which one do you think would be most impactful in the next couple of years in academics?
With regards to,
Which benchmark do you think would be focusing on, like either women train, like from a bottom-up grassroots methodology, or maybe from a top-down methodology? Um, I mean, naturally, all of it is very important, but
I was just going to say all the above. I was like, which one? I really actually think it's the biggest problem to me, I think, is maintaining and feeling supported, right? We can get people into residency, for example, but we find out there's actually a pretty decently high drop rate. And that's a problem, right? So I think the benchmark for me would be sustaining, from year to year to year, how many people remain in it, not just PGY1, but at PGY5. And that would be my personal benchmark. There is higher underrepresented minorities that have dropped out of orthopedic residencies in the last 5 to 10 years. And that is a concerning number and something that we don't want to keep going. And we need people to feel supported. Doesn't matter what you are, man, woman, underrepresented minority or not. And that would be the benchmark I would look at. It's not an easy benchmark to note. Someone who's dropped out of residency or people who stop practicing. People who stop practicing, is it because they retired? Is it because they retired early because of some other reason? And we don't keep a good record of it or are able to delineate it well.
Yeah, I agree. I mean, I think if people in the U.S. Haven't gone to the Academy Educating course, it really is an eye opener. I have no conflict for it, but I just finished it. But they do talk about different ways, because we all know there's so many different ways that people learn. And if you're trying to teach one way and you are an educator, you're responsible for educating them and making safe surgeons. But you have to know that there's more than just one tool in the toolbox. You don't have to, it's not just a hammer. Sometimes you have a drill or a screwdriver or other things too. So I think it's just it allows you to become a better, more diversified educator. So I think it's good to, understand that people learn in different ways, and we have to meet them where they're at. So just like patients too, so.
Right. And actually, Dr. Weber highlighted this very nicely in the Q&A. She's saying how she's been in programs that consistently had greater than 35% women residents, which is over the tipping point that you're talking about boards, which is a really good point, and diversity, but you really need the inclusion and belonging. You need to feel like you're part of the group. Yeah, you need to feel like you don't stand out or you don't belong there. You have to feel like you belong. And then you're part of the fold, because orthopedics is a family. I think we all like orthopedics because we actually really like each other and we like what we're doing. And I think the key factor is we all, we see a nail, we hit it with the hammer. Like that's what we do. It doesn't matter what you look like or how you act. You feel like you belong because you're part of the team and you're here to make the patient better. That's really what matters at the end of the day.
Excellent for that. Thank you so much. Uh, I think we can move on to our last article. Let's bring it home. This is patient-physician racial concordance increases likelihood of total knee arthroplasty recommendation.
Let's see. Are we seeing in slideshow mode?
No, just the
Not yet. Yeah, the draft
Okay.
mode.
Better?
There you go. Looks
looks
great.
good.
Okay. So this is a paper out of Northwestern University Hospital and Med School by Suleiman et al. Titled Patient-Physician Racial Concordance Increases Likelihood of Total Knee Arthroplasty Recommendation. So yeah, again, this is in the Journal of Arthroplasty, Impact Factor 3.8. This was a retrospective review of prospectively collected data investigating patients with hip or knee OA, aiming to determine whether surgeon likelihood of recommendation for total joint arthroplasty is related to racial concordance between surgeon and patient, racial concordance, and whether racial concordance is an independent predictor of surgeon recommendation for total joint arthroplasty. I think the main kind of impetus for the study is that in other fields of medicine, more primary care focused, racial concordance has been shown to increase compliance and outcomes for patients, but has been less studied in orthopedic surgery. And to the author's knowledge, no known studies had examined the role of racial concordance in TJA, particularly TKA, which this study is focused on. So there were 402 patients recruited from the clinics of 4 fellowship-trained arthroplasty surgeons at Northwestern University. 1 self-identified as Black, 2, and then the 2, 3, and 4 self-identified as non-Hispanic white. Patient and clinical and demographic data were put into the AOS appropriate use criteria, OA of the knee, surgical management. Out of that, 314 patients were considered appropriate for TKA. The others were either deemed appropriate for unicompartmental arthroplasty or other interventions. Then there's a retrospective review of the medical records for whether there was a recommendation of total knee arthroplasty, and along with many factors of sociodemographic data. The primary outcome was recommendation for total knee arthroplasty from the treating orthopedic surgeon. And all patients, regardless of their appropriateness based on the AUC guidelines, were included in the analysis of racial concordance. In the definition of racial concordance, so it's basically a match between the racial, self-identified racial category of the patient or the provider. So for the results, 314 patients were deemed appropriate for total knee arthroplasty. Average age was 67. Self-reported race, 45% were non-Hispanic white, 36% were Black. 10% Latino, 6.9% other. So for this paper, because of the lower numbers of other racial categories, the main outcomes and analysis was based around Black self-reported patients as the one non-Hispanic white provider self-identified as Black. 39.2% overall received a recommendation for a total knee arthroplasty. And overall racial concordance associated with increased likelihood of receiving a recommendation for a total knee arthroplasty of 24% versus 13%. Black patients who had racial concordance with their provider were significantly more likely to receive recommendation for total knee arthroplasty than non-Hispanic white patients with racial concordance at 55.1% versus 23%. And racial concordance was found to be an independent predictor of total knee arthroplasty recommendation. So a few things stood out to me. I think the methodology was sound overall. I think the design of the study for the projected outcome measures was sound. I'm curious of the others' thoughts on the prospective recruitment instead of making this a fully retrospective study, which I think could have been achievable, although they may have not been collecting the self-reported racial identifiers of the patients. I think this could have potentially introduced a risk of bias. This was a level 3 observational study. One more critique, there was no data presented on how many of the study patients ended up actually undergoing total knee arthroplasty, and I think it may have been due to the timeline of the study, but I think this may have been a missed opportunity to understand even further factors in inequity in total knee arthroplasty in terms of barriers to patients actually being able to go through with their knee replacements. And then the other main point I was curious about was the potential effect of resident interactions with patients and racial concordance with residents, or just independent factors and with that resident interaction. As we know, as residents, sometimes we spend a greater proportion of the visit with the patient than with the attending surgeon, and that wasn't discussed in this paper. So I think overall, we took away the main point that racial concordance is correlated with increased rates of recommendation for total knee arthroplasty. I think there's some more details to uncover with this in future directions. So a question that I had, and I think that was a kind of a next step of the discussion is the goal to get perfect racial concordance so that we have every patient has racial concordance with their provider. I think it's an interesting thought. It may not be practical or may not be the goal, but are there modifiable factors that we can work towards to improve the equity in terms of allocation and I guess offering of these procedures that patients may need.
Love it. Let's leave it on the last question there.
What was that?
If you go back to the last slide.
Yeah.
Yeah, it's always one of those important things. So, it's one of those tough areas where, these are all observation studies, not causation studies, right? You didn't go to the patient and say, hey, did you choose to do surgery or not choose surgery because your surgeon was X, Y, and Z, right? This is all kind of retrospective and kind of bringing these together. But I think the conversations could be different from different individuals, kind of with the same with the cultural background. If you see or hear someone who looks like you, understands you, relates to you, and that can be for a variety of reasons. Like I had a patient who I knew a colleague who had Ehlers-Danlos, and then they talked to a patient with Ehlers-Danlos, and the patient just felt much more comfortable, right? So something about that people can relate to. The hard part is modifiable human factors. And that's a really, really tough one because, born as one person and I'm not changing, right? Like this is who I am. But I think really what it comes down to is recognizing, for the same reason we talk about residents being inclusion and belonging, is also for patients to feel included and they belong there too. And feeling heard, I think, is a big thing. How many times have you seen a patient that who comes in and been like, oh, my surgeon spent a minute with me and just left and told me I just needed surgery and don't tell me why. And that's not a positive feeling. So I think actually having the resident presence there is a bonus. I know the residents tend to take a little bit more time in the room, but that can be a really good thing, right? Because you sit there and you talk to them about the risk and benefits of surgery. And my risk and benefits talk is pretty, streamlined and brief, but there may be a lot more questions, and I try to answer as many questions as possible, but some more may come up that I feel more comfortable about. I always tell patients at the end of each surgical discussion, even if they sign up, I say, feel free to reach out for my chart for another set of questions. We can always do another telemedicine visit, or I can do a phone call where we can talk about more questions. And I think that just puts people at ease in theory. But, the modifiable risk factors is understanding, saying, identifying certain cultural things. A totally different thing. I was in South Philly for fellowship and I practiced it as an attending. And I would talk to them about sauce. And sauce, for you guys don't know, is Italian, like marinara sauce, right? And I grew up, so they talk about gravy because they called it gravy. And my mind, gravy is what you put on turkey, and that's that brown stuff that you put on. But for them, gravy can be the actual like red stuff they put on pasta. And just being relate to and understand them. I'm not Italian, as you can probably tell. I have an Italian first name though, and that was actually a point of relating to patients for interesting things. So I think identifying and being able to connect with each other if you're human makes a big difference.
Great presentation, Hannah, and really something to kind of discuss and talk about. I think the study is good. I think that it really highlights and really brings forward the conversation. Um, there obviously there's some, or naturally there is some challenges with the retrospective study or having a small surgeon series. But you know, um, it's important to have these like patients really care about these shared experiences, because it really, that relatability can be really important for them. And it's more than just, and I think there are some articles that support this as well. It's more than just about race and ethnicity. It's these other socially determining factors that also play a role. And one thing that we didn't like, such as like previous health experiences or even community trust or mistrust in the healthcare system. And I think these are things that we have to understand that patients have, and we have to find ways, because they're challenging, ways to kind of work with them. Communication is another one. And so you can kind of read these articles and understand that there's other mechanisms that are driving these patient interactions, and such as trust or communication, these thresholds that have to do with people that have that same experience or may look like the same individual, doctor to patient. So I think it's really important in all, and I think a lot of these articles highlighted kind of to that point that everyone's had a different lived experience, and we have to celebrate that. We have to celebrate everyone's individuality and understand that we're all different, and be okay with that. And so I think that that's really important. I guess my one question to Dr. Chen is, what do you, and this is something kind of, I just briefly talked about it. We haven't really talked about for the other articles. Um, you know, Certain patient groups or certain patients in general have a mistrust of the healthcare system, or et cetera. How do you how do you particularly try to, um, because a lot of those patients are very charged, how do you disarm them? How do you make them feel more at ease, when, a lot of times we try to achieve concordance with the patient and physician relationship, but oftentimes it's a discordant relationship, and that's okay. So, what is some of the tricks that you like to use to help care for these patients?
think it depends on the patient, depends on culture. I will say something that I'm not very good at is being touchy-feely. I am not a touchy-feely culture, but I was schooled. One of my patients, who happened to be a nurse, um, complained about me to one of my colleagues, and said that I wasn't warm and caring enough. And I'm like, I think I'm pretty warm and caring, but I didn't give a hug. And that was, or didn't put my hand on her. And that was an awakening call. I didn't ever do that in the North. In the North, people don't do that. You don't touch each other. You don't do any of that stuff. In the South, you hug. So it has been something that has changed my practice, just by a geographic move. And I will say that has actually really helped me practice. I tend to do that more for my female patients than male patients, but it depends. I have some male patients who really want to hug. And so that has been one move that has been different for me. Again, I didn't grow up in a household where we touched, hugged, anything like that. That is my Asian upbringing, and I've been doing that more and more. And I feel like it connects with patients more, and it's, brings a smile to my face, brings a smile to their face, and that has been for myself a big changer. How about for you? Is there anything that you've done as tips and tricks in your practice that's changed?
As I take care of, different types of patients, more challenging patients, patients that may have had a previous infection, I've become a little bit more religious now. And I think just being able to relate to patients, being able to be very inclusive, and just be there for them. I think that they really care for that. I always like to sit down when I talk to them and just look at them eye to eye. And I know it's sometimes hard because the keyboard is right there and you have to chart, but I definitely want to make them feel that they're spending time with you, because it doesn't matter. And this is something that someone told me a while ago. It doesn't matter how smart you are or how much you know. If they don't think that you care about them, then whatever you say or decide doesn't matter at all. So I definitely try to take that to heart every time I step into the room, so that I know that they know that we care for them. So.
Love it. I know that we've been the one who's talking, but do the residents have the same thing to say? You guys are allowed to speak up as well too. You guys see patients in even a worse state because they're in the emergency room and they're scared or hurt or all these sorts of things.
I've been thinking of one scenario, actually, if it's okay to share. It was with a pediatric patient. She was a little girl with her father they were Afghani. We're in Sacramento here. We're actually one of the biggest refuge cities in the nation. So we have a lot of different cultures. We see many supracondylar fractures, like multiple a day. I think I had like 6 that day. And hers was, type 2/3, so something routinely that we would recommend pinning for. And the dad was very, very adamant about refusing surgery. I had multiple conversations with him, and I think it was doubly challenged by the video interpreter that I wasn't sure I was communicating in the kind of nuance that I was trying to describe. And the dad was saying, oh, my other child had an arm fracture and she's fine, and trying to explain the potential consequences of malunion. And it was difficult. I spoke with my attending overnight, and ultimately, I think we did the best we could in communicating the risks and benefits, and the decision was still to not do surgery. And so I think at other centers, reducing supracondylars is more routine. It's not really at ours, but we did our best. We did sedation, we got it reduced, and it was challenging, but also important for me to kind of get to a point of having some flexibility and kind of questioning our own dogma and our own practice, and accepting that it's someone and is capable of and has the right to make a different choice, and then doing the best job that we can within the confines of the choice that they're making. And so that was challenging, but I think an important experience for me.
Thanks for sharing that, Hannah. Excellent.
Yeah, I think I had a kind of similar, not similar experience in that sense, but kind of like an eye-opening experience throughout residency. I kind of noticed it as I kind of went by, is we have, you know, obviously diverse population up here in Minnesota, and anytime I would be in clinic and I mean, you know, if the patient is Middle Eastern, they speak Arabic and they're seeing the attending, and I'm kind of just in there, and they're talking. They seem very skeptical about things, and I feel like you can tell when someone is skeptical about things. Then I kind of open up and speak a little bit of Arabic with them, and it's suddenly all of a sudden that kind of barrier, that defense mechanism kind of falls away. And they start talking to me more than the attending that I'm with. And I'm like, I'm not the one who's going to do the surgery. I might be off rotation like next week, but I'm happy to help. But that kind of that barrier falls very quickly as soon as they see someone that they can relate to. So it's kind of interesting. And I feel like it's a lot harder when there's discordance than when there is concordance between the patient and the surgeon. But I think also like noticing that experimenting with certain things, like even bringing up some of their history, and when you come into the room, I feel like has been pretty helpful, because some patients sometimes they get annoyed that, oh, why is the resident coming in? I'm here to see Dr. So and so. And then as soon as I bring up, or like, oh, I've seen that you've done this and that for this, and they immediately kind of starts get them going, and they start talking to me as if like I'm their actual surgeon, which I think is interesting, like just showing some interest, or like, oh, I know about what you've been through to get here, and I'm here to help. So I feel like those things are kind of eye-opening at least, and we'll see how that kind of changes my practice in the future.
I'll
Yeah,
be
that
calling you when I have an
patient-physician
Arabic
relationship.
patient. Sorry, sorry.
That
Go ahead.
patient-physician relationship is really strong. I think that's one of the things that is invaluable to us. You can't really place any sort of price on that bond that we all develop. Well, I'm sorry, go ahead. Well, I do want to definitely thank everyone for spending the time and
Oh.
talking a little bit about, again, that science of diversity. Yes, one more thing.
One more thing from Professor Eastwood. She said it's crazy, but if I don't actually formally examine a patient, I always touch them in some way for human contact. So I appreciate that. That is something that has actually made an impact on me too. And I've had patients who come in and see me. They're like, I saw another surgeon and they never touched me, and not in like a hugging or touching way, but like didn't even examine me. And they go, well, that's really a mistake. So it is. I agree. Human touch makes a difference. So I just had to highlight that comment and commentary in there. So thank you, Dr. Weber and Professor Eastwood, for speaking up in that way.
Thank you so much for that. Yes, they have a long lineage and heritage of training and teaching, and a very deep knowledge base to pass along. So it's wonderful to hear from them. Thank you again for contributing. Um, I just wanted to say thank you so much, everyone, for coming and discussing again the science of diversity in orthopedic surgery. We know now that these articles really highlight the human touch and the human contact and just the human condition about trying to take care of one another. Here in the U.S., we're very fortunate to have many different shared experiences worldwide as well, and being able to kind of just celebrate everyone's um, diversity together, all these shared experiences, all these lived experiences into one giant melting pot, which makes up the United States of America, which we all love, and the world as well. We celebrate diversity worldwide because everyone has different viewpoints and thought points, and we should all be respectful of one another and really cherish those moments that we have when we can spend with each other and discuss those moments. So thank you again, everyone. It's on the hour, and I want to again thank everyone for their time. So everyone have a good night, and this will be available on the website. So thank you.
Thank you for organizing, guys, and thank you guys for all preparing those articles. They were excellent.
Thank you very much.
Thank you.
Nice job.
Thank you.